Okay, good afternoon, everybody. This is Carmen Rosa from NIDA CTN office. Welcome for our third installment of our Data Science Technology webinar series. We will have Dr. Amar K from Dartmouth. Before he begins, just wanted to let you know that this webinar is being recorded. If you have a problem with that, just let us know. And the lines are muted at this time, but they will be opening for questions at the end, and we will be unmuting them. So I just wanted to make a very brief introduction. Dr. Das is at the Geiser School of Medicine at Dartmouth and is the founding director of the Biomedical Informatics in the Department of Biomedical Data Science. He's also the Associate Professor in Psychiatry at the Dartmouth Institute of Health Policy and Clinical Practice and Director of the Biomedical Informatics Core within the Dartmouth Synergy Clinical and Translational Science Institute and Head of the Informatics Collaboratory of Design, Development, and Dissemination. He received his medical degree and PhD in Biomedical Informatics from Stanford University and completed a research track residency and postdoctoral fellowship at Columbia University / New York State Psychiatric Institute. He was an assistant professor of medicine and at the Division of Biomedical Informatics of the Psychiatry and Behavioral Science at Stanford until 2012. Today he's going to present a very interesting webinar called Mining Big Healthcare Data, Tales from an Informatics Odyssey. And he's going to discuss issues like reuse of electronic health record data for research, evaluation of data quality in health information systems, integration of data from multiple sources, and mining and analysis of treatment pathways. Plan is to have plenty of time at the end of the presentation for questions and also any ideas for opportunities for research in the CTN. So we would like to welcome everybody to the webinar, and especially would like to welcome and introduce Dr. Das.
Hi, thank you very much, Carmen. It's a pleasure to speak to this group and to have an opportunity to participate and collaborate through my colleague Lisa Marsh here, who's at Dartmouth and recently joined the NIDA CTN as a member from the Northeast. So as mentioned, I'm going to be focusing on talking about the use of data that's coming from electronic health records, some of the opportunities and challenges that come from using that data, and that can inform us as we do work in clinical research. So I just want to first note that there's no conflict of interest to report with any commercial interest in my presentation. So in terms of big healthcare data, we're seeing more and more data being collected within the health system at this current time. A lot of this is because we've spent the last few years deploying electronic health record systems throughout the country in academic medical centers, in large hospitals, and more increasingly in primary care settings. And there's been, as many of you know, a lot of incentives for the health system to use this technology effectively to help with gathering data about patient care, as well as using information to look at population-level patterns in the data. And so what this slide just shows is there's a number of ways that we're collecting this information now. It's coming from a variety of sources. Here we're seeing, for example, patients who've been come in, had a chest x-ray that suggests pneumonia, and then a variety of treatment pathways that are emerging because of that, either getting antibiotics, getting further diagnostic tests, and so forth. And there's a lot of variability, as many of you know, in how patients go through the healthcare system, even with the same diagnosis. So we're seeing a lot of this information being collected in electronic health record systems that we have. Although we're seeing this information here in sort of a graphic form, the data is quite different in different settings. So information might be collected as coded information, like ICD-9 codes. It might be collected in text. might be collecting images, reports, and so forth. So we have a huge variety of information that we're gathering right now, which is our source of big data. When you hear people talk about big data in the field right now, there's a number of things they talk about in terms of what's called the V's of big data, the volume, the scope of the data we're getting, the variety, as I mentioned in the previous slide, electronic health record systems, we're gathering a large variety of different types of data. Velocity talks about the speed at which we're getting the data, and very importantly, and something I'll be touching on today's presentation, is the veracity of this information that we're collecting. A lot of this data is being collected for clinical purposes at the level of precision that's necessary for clinical care, but the question is how well can that information be used in terms of research and understanding how patients are doing. Other people have mentioned other V's, and I think these are relevant to healthcare. So what's the value of this data? Not all data is of equal value. Viscosity is sort of a term that we use to say how actionable is this data, how useful is this data to at point care. Because of the scope of the data, there's a lot of work going on data visualization to be able to present the data back to end users, whether they're health professionals or patients or the healthcare administrators, so they can look at those amount of data and the variability of the data. The data is not of all the same sort of quality, and there's other factors that go on in how the data is being collected. And as many of you know, some of the big changes that are occurring on the healthcare system, like switching from ICD-9 to ICD-10, creates all sorts of issues in terms of how we look over that time period with this information. So we have lots of challenges when we think about the data we're collecting, and we really need strong data science approaches to be able to deal with these issues. So just in kind of a high-level summary, I want to just mention that when we look at this big healthcare data, there's the most important thing that we find is the data quality is an issue. And I'll show some of the work that we've done that indicates this as a problem. And the complexity of the data, that it takes some time to be able to sort through the information to be able to find out what's valuable. So some of the basic issues that we're faced is that the data that we get out of the electronic health record system, it's structured in a way that's efficient for the computer to manage, but the clinical context in which the information was collected is lost sometimes. So we have to reconstruct how we interpret the information. When we look at the data sources, there's a variety of ways the information comes in the system, and there's a degree of error associated with that. So for example, when we look at diagnoses, we can look at the ICD-9 codes or ICD-10 codes associated with the patient encounter as one source, but as some of you know, that's a very high-level source of information. We can go into a problem list and see what the healthcare provider said was the problem for that patient, or we can find other sources of information where we think that help us with diagnosis. And so one of the challenges is just trying to figure out what conditions a patient has in terms of identifying cohort of similar patients. And so this all leads to the fact that when we are interested in using these electronic health record data and looking at this, we have to really do a bit of data exploration. And I think most of us who work in this field start to realize that we have to build in this time, that we can't just take the data and within a day or two create variables that will then become useful for research purposes. We'll have to work through a process where we gather the data, clean the data, and ensure the data is high enough quality for research purposes or clinical purposes as well. So I'm going to talk a little bit here in terms of a project that I undertook which was at Stanford and also was in collaboration with the Palo Alto Medical Foundation, which I'll call PAMP. This is a project that was actually started by a donor. It was a $3 million gift to the two institutions. The donor initiated this project because the donor, Dick Levy, is the ex-CEO of Ryan Medical Systems, which is a company that creates radiation oncology technology in terms of radiation therapy. And this individual had a number of friends and colleagues who've been diagnosed with cancer, had gone to a variety of places within the Bay Area and elsewhere, and every time the patient went to someplace else, they got a different set of recommendations. And so it was very clear to this individual there was a lot of variation in how patients were entering the healthcare system, what treatments they were being recommended, and he wanted to understand how we could try to sort of sort through that by looking at the data we're collecting. So through his funding, we were able to create an informatics resource that would allow us to bring together data from a variety of sources as well as data from multiple institutions. And I'll tell you why that's important in a second, so that we can look at these patterns of care and understand what some of the factors were that were driving treatment decisions in this case. And I think that in terms of thinking of what NIDA is interested, these are all, we would be interested in looking at patients who potentially have substance use and trying to gather data from a variety of systems and variety health systems as well as electronic systems to be able to look at the full pattern of care for these individuals. So this presentation is going to focus on breast cancer, but many of the factors I'm going to talk about is quite applicable to substance use disorders. So the reason that we chose to collect data from two different institutions together was just the nature of the geography of how the healthcare system works in the Bay Area. So what you're seeing here is a Google map of Stanford Hospital, which is located on the Stanford campus, which you'll see is on the bottom half of the picture. And across the street is with El Camino Real, the main street cutting from San Jose to San Francisco, is the Palo Alto Medical Foundation. So this is two sites of care that are a mile apart from each other. And it's well known that patients will go back between these two sites. So one of the issues we'd have is we had looked at one single institution, looked at patterns of care for that institution. We would have missing information about patients who then went to another system and got care there. So we wanted to make sure that we try to integrate. Now there are other sites that we would have could have integrated into this, like Kaiser and other settings, but it turns out that these two sites share enough patients that we were able to develop a cohort of patients around breast cancer care. So again, when we look at the health system, we want to make sure we gather as much information as possible from all the systems that the patient is going to ensure that we have a complete picture of their care. So in summary, what we did with creating this informatics resource is that we were able to collect longitudinal data over time from about 18,000 plus patients who received breast cancer treatment at either of these two sites since 2000. And so this actually predated some of the electronic health record systems. It went back to older systems that were in place, systems that were used for billing, systems that were used for specifically for registries and so forth, that we could gather the information. And one of the things that we have to determine when we look at this data, there's a huge amount of data elements that one can gather. So the first step is just deciding what portion of the data is useful for a purpose of research. In our case, we looked at about 400 data elements, where we looked at the demographics, obviously very important, but information coming from pathology labs, imaging, other tests, and so forth. One of the things that we also had access to was the clinical notes, procedural notes and imaging notes, which I won't talk about today, but which is another opportunity to look at data. Some people estimate that about probably the 70% of the clinical value of information within electronic health records is in what we call the unstructured data, the clinical notes. So this is important for us to tap into to be able to uncover other aspects of care that are not coded in the healthcare system and then electronic health record data. So first issue that comes up is data quality. This is from a blog, from a statistician. Why are so many men pregnant? There are a number of coding issues that come up with this data, and it's always surprising what one finds out in terms of how these codes are mentioned. There's, for example, men who have been coded as having pregnancy and diagnostic codes. There will be in a children's hospital people who are age 99 plus. There will be all sorts of other factors that don't make sense. So looking at each data element, ensuring the quality of that is very important. Some of these factors are, in a hospital with a child who's 99, it usually means that they had been coded that way because they didn't know the true age of the child. But you don't know that necessarily when you see the data at the other end, that's the coding. So try to figure out why there's these discrepancies is an important part of the data exploration. So what we did in terms of trying to figure out how to gather a cohort of patients who had breast cancer, we had to think about the variety of sources of data and truth that was out there. So if we went to our Stanford electronic health record system and we made a query and said, how many patients have had an ICD-9 diagnostic code of breast cancer, we'd get about 10,000 patients. If we went over to PAMP, the other site, and asked the same question, we get about 8,000 patients who had that code. Now, in addition to this, we know that there are registries that that collect information on reportable cancers. So there's one institutional registry at Stanford, and there's an institutional registry at PAMP. And we also have a regional registry in the Bay Area where these two registries and other local registries send their data. So those registries capture information about the incident cases of breast cancer. And as you look at this, you'll see there's a number of discrepancies in terms of the sources of information. And so we want to try to sort through that. So the registry sources, as many of you know, are systematically capturing the incident cases. They're trying to find out new cases of breast cancer. And in this case, there may be some overlap between Stanford and PAMP in terms of registries, because both of these registries may think that they've caught the incident case and they duly report it. The CPIC, the regional registry, can try to sort that out for us. One of the challenges we have with the registry source, though, it doesn't gather information about treatment. So if we're looking at treatment from the perspective of the healthcare provider, the breast cancer may have been diagnosed somewhere else, not be caught in the registry, and then the patient's still being treated at the institution. So that patient is missing from the cohort if we don't consider the treatment factors. So the EHR data, the other source of data, that it provides these coded information and the clinic notes, as I mentioned. And it can also indicate when patients came in for consultations and when those patients had not necessarily been diagnosed at that institution. So because of these different sources of data that's available for us, we have to come up with some kind of uniform criteria to think about how we will include patients into a resource that's meant to look at breast cancer. So this is just an indication of some of the challenges here when we look at the different factors when we try to consider these as criteria for including patients. So as I mentioned, there was about 18,000 patients, but this is a slightly smaller cohort because of the criteria being shown here. So the bottom green part shows us patients who are in both the registry and in the encounter data, which is the used for billing. And then the darker olive color, khaki colored green just shows us patients who show up only in the electronic health record billing data. And so you see there's a large number of patients who don't show up in the registry, and there's a small percentage, surprisingly, that only show up in the registry but they have no encounter that was billed for in the electronic health record system. So that takes a little time to wrap your mind around why that might be the case, but there are some individuals that the registry has captured that never were encountered in terms of or at least documented from the billing counters as a patient at the institution. And so the first column just shows you what happens when you look at the first criteria, diagnostic code of breast cancer based on ICDI. And we know that there's going to be a number of patients who show up in the billing data who will have this diagnostic code, who are not in the registry for valid reasons. One is these are patients who may have a history of breast cancer, so they got coded for breast cancer, but they're not an active case. The patients who are coming in and getting ruled out for breast cancer will also get coded for breast cancer, and there will not be appear in the registry. So there's a lot of false positives clearly in the top half of the bar, the khaki bar. As we try to tighten up the criteria a little bit, so we also know which specialists at both of these institutions treat patients with breast cancer. So if we just use that without looking at the diagnostic code, we see that we get a smaller number of patients, and we do get some more less false positives as we might think about potentially, and also, we also miss some patients who were just in the registry. And then if we look even more strict, we say who of these patients saw a specialist who gave them the diagnostic code of breast cancer, so we're tightening even further. We get a smaller number, a larger number that only appear in the registry, and we think we're getting sort of closer to truth. Now, what we end up doing for our papers and analyses is that we decide to build the cohort around the registry, and we had a very set strict criteria, including patients who were just appeared only in electronic health record data. And those criteria included a number of visits they had to make. So we decided that they had to at least make 3 visits to a medical oncologist, radiation oncologist, or breast surgeon to have been actively seen as being treated with the institution. And that became our final cohort for that. But one cannot just simply take the data and expect the codes to be revealing in terms of the accuracy of the diagnosis the patient has. So then once we've decided who should be in our cohort, we then think about each of the data elements that we want to pull from these variety of resources. And what I like to point out is that if any time there's a registry that's collected data, that is probably the best source to start with. And so in California, we're fortunate that all the institutional registries and all the regional registries report up to the state cancer registry, which is a SEER registry, one of the standardized ways of collecting data on patients with cancer. And from that, we can always get information about the patient and the information about their tumor. In the institutional registries and also in the regional registry, we have some information on when patients received a particular modality of care, whether it's the surgery or hormone therapy, chemotherapy, radiation therapy. And so that gives us a high-level view. And we also know what site they were given these treatments as well. Whether that's complete or not is another issue, but at least we know at some point that the patient may have been seen outside the system. We can then look at the more detailed information about the specific encounters by looking at the data from the electronic health record. So looking at who the provider was, what happened in the encounter, whether there were labs, other diagnostic information that comes there. Those information are not collected by registries in general. So we have a way of integrating the data across these different sites to be sure that we can have a complete view of the patient from the different resources. Now, the other challenges that we had in terms of sharing data is, this is what quite common, is that institutions don't want to share their data with another institution, partly for business reasons. So here we are looking at the quality of breast cancer care or variability, and the two institutions, Stanford and PAMP, have a little economic, competition between them. So they want to make sure that they don't reveal their patients to each other, and we give them high-level information. So looking at these different sources of data that I just mentioned to you, the registries as well as EMR data, we pull those data elements that we think that we want, and with the cohort definition. And to share the data, we did some interesting work where we created a new digital fingerprint for each patient that de-identified the patient information. So we found that if we took the first 2 letters of the first name and the first 2 letters of the last name plus the date of birth, and we used a computer algorithm to create a digital code from that through what's called a hash, which is only one way, so we can't reverse engineer it back to the patient's name. Then we had this unique digital fingerprint, which is a de-identified piece of information. And so if they're a patient at both sites that actually have the same name, first name and last name, and the same date of birth, then when they get this new digital fingerprint, if they've been seen at both sites, they'll actually have the same ID, and we can integrate the data across 2 sites without revealing any of the PHI for that patient. So that was an interesting challenge to have, and allowed us to get around some of the other legal and also regulatory issues around this data. So we have this shared database that we create. We both send our data there. If they link together, then we know that's the same patient. We did some validation to show that this had a very high accuracy in terms of the hash code. It's actually better than using the Social Security numbers, which also we had with the patients. There were a number more errors in Social Security number than we generated by patients who might have very similar names or may have had changed their name or something like that. So once we create this anonymized data and aggregate share it between the 2 institutions, which is the OncoShare project, then we can create databases for researchers to use from that. And this is an ongoing process we've been working on. Since I left Stanford in 2012, there's ongoing data collection. We've also pulled in data from genomic information from patients, imaging information, and so forth into this database, and continuing to write a number of papers from the work. But this took us a while to get together. This process I was mentioning took about a year of data exploration, a year of going through some of the regulatory processes, which we could have, I think, in retrospect, kind of streamlined since we knew later what we were trying to do, and finally got that right to the point where we could give the data out to researchers to be able to publish papers from this. So here's some of the issues that we found in terms of looking at the data we had collected. And so first of all, we were interested in looking at what's the rate of treatments across the various modalities from Stanford and PAMP. And so this is the number of patients at Stanford was just 8,000. Now these are patients who may have been seen at PAMP, but we hadn't linked them yet, just to look at the unique rates between the 2 institutions, and about 6,000 at PAMP. And what you'll see, if you just read across, you'll see that the rate of mastectomy is 43% at Stanford versus breast-conserving surgery, which would be less, which is 57%. And the rate of mastectomy at PAMP is 38%. But then when you look at the sources of data, you'll see some of the issues that come up in terms of quality. So from the billing records, these are the encounter of data that comes from electronic health record system. This is where the physician or the health provider is going to record a diagnostic code or a procedural code in this case, and enter it into a system. You see that the rate, that means the perceived rate of how many patients receive mastectomy, is only 22%, versus the registry, which has where a registrar has manually gone through the records, looking at notes and other pieces of information, and looked and found a rate of about 41% just at Stanford. So there's a twofold discrepancy here between the billing records and the registry records. And you'll see that it's higher with the chemotherapy. You can see that only 10% of the chemotherapy was captured in billing versus 40% within the registry. And the same pattern exists at the other institution as well. So this is not an institutional specific challenge with the data. It's both institutions, the billing information is not, the encounter information, surprisingly does not capture the clinical activity, whereas a registrar who is manually going through this information is more able to find this. Now you can see the registrar is not complete because their rate is still slightly less than the total rate, which is the integrated truth from both the billing and registry. So the 43%, for example, reflects whether the patient received mastectomy based on billing or registry at Stanford, and 38% based on billing or registry at PAM. So now we can see the rates compared to this. And now we're going to link the data and see what happens in terms of what happens with patients between these two sites. So this is the rates of treatment after linking. We look at mastectomy, chemotherapy, radiation therapy, and you'll see if you read across just the mastectomy that the rate of treatment is 56% for patients who had received care at both institutions. So these are patients who got diagnosed at one institution and got treatment at another one and went back, got another treatment. So patients who are moving back and forth in the two systems. And you can see that if we hadn't linked this information, we would not see that there is a higher rate of treatment use. Both mastectomy, chemotherapy, and radiation therapy, that's statistically significant between these two institutions. Okay. You'll see that once the linkage happens, another interesting thing happens is that the billing data, we're able to capture more of what's happening. It's actually getting better. So having more data helps us to look at where things might be missing. So by being recorded in two systems, for example, we have a more likelihood chance of capturing that the patient actually got the treatment for that particular modality. So this was quite revealing to us. This is a paper that was published last year in Cancer, looking at the use of linking data between systems to reveal patterns of care. And again, what's surprising is the fact that we have the patients who went between both systems ended up using more care in general. And as this project, the OncoShare project, also included a qualitative aspect of research to it where we did focus groups with the patients to try to understand what factors were driving their healthcare decisions. And we also are now doing work on having journals that we give to the patients, electronic journals, where they help us in real time try to understand what choices they're trying to make, so we can look at some of these either patient-based factors or system-based factors that leads to the increased use of these treatment options. Now, what I showed you there was the treatments, but we also looked at the diagnostic information as well, and you see another very similar and very curious pattern, which is here we're looking at the use of MRI, breast MRI, for diagnostic purposes. MRI can also be used for kind of monitoring after a patient gets the treatment to ensure there's no relapse or recurrence of the cancer. But if we just look at the time in the diagnostic use of MRI, you'll see here first the bottom line, the light green line for PAMP. You see that there was no MRI use there until 2006 when they installed their MRI at PAMP, and then the rate of treatment, rate of use of the diagnostic test went up to about 30%, which is about what you see Stanford has gotten to over the years, to about 30% in 2009. What's interesting, though, is of course both patients who were seen at both institutions for care, and starting in 2002, they are increasingly using more and more MRI, up to about 70% of the patients who are seen in both institutions got a diagnostic MRI versus 30% for those who were just had their care at one institution, more or less. So another revealing pattern that's happening when you look at the population level of all the data we're collecting. So another factor, and this is in terms of when we think about clinical trials and protocols, we are having patients being followed through these very complex set of factors. And here we're looking at part of a guideline for breast cancer that is part of what we would consider to be personalized medicine now. So patients who have breast cancer that's early stage in this case and are hormone receptor positive, they may be recommended for using a 21 gene assay called Oncotype DX. It's a commercially available test, and this the use of this test will help determine whether a patient with a stage 1, stage 2 early stage breast cancer should go on to get chemotherapy based on the genes that are present in this gene test. An interesting challenge for us was that the Oncotype DX test is something that is ordered out. So you send the sample out to this company called Genome Health, and they send you back a result. And so when we went to look in the notes whether this was actually mentioned, that the use of the test, we didn't find a lot of occurrences of being documented, even though we thought more patients would be getting this test, given the numbers that you'd have. So we actually worked with Genome Health to send them our medical record numbers, and they gave us back the information about which patients in our cohort had received the test, as well as what their results were. And this is a paper we're putting in now, currently, but there were a large number of patients. Only about 20% of the patients who should be getting the test were getting the test done. So they actually probably reflected closer to what the notes were indicating. And then the information about whether the recommended action here in terms of the score was being followed in terms of chemotherapy, something that we're continuing to work and analyze. But as we look at how to monitor patients across these complex guidelines and clinical trials, we need to understand how we can better capture the data so we can help to understand where they are in these various workflows of treatment and diagnostic workup. So I'm going to talk next about how we approach some of this data. We use a lot of statistical measurements, studies, as I mentioned, to look at some overall patterns, but then we want to look at the information longitudinally to be able to look at patterns of care within the data. And so, as I mentioned, let me just go back to the previous slide, there's a lot of variability in how patients are going through the system based on the types of care they're receiving, whether they're receiving certain tests and so forth. And it's very hard because of this variability, to come up with a way to summarize the patterns across the data. So what we did was we used the technique that's been developed for bioinformatics, which is a program called sequence alignment. Sequence alignment is used in both gene sequences, protein sequences, and other biological sequences to measure the similarity between sequences. And as many of you know, the sequences vary across species because evolutionary pressures within humans, because of genetic mutations. And so by doing a sequence alignment, one can find similar sequences that are similar to each other. We had the idea, working with the healthcare data, because of the messiness and incompleteness, the variability, that if we use the sequence alignment approach, we might be able to find common pathways that were occurring through our data. So instead of you thinking about using the genes or the proteins, amino acids, or the base pairs that are in genes and proteins, we would make the events for the patient care the source of the sequence. So our sequence is what happened to the patient, the ordering of the various factors that happen as they walk through the healthcare system. And this is a part of a bigger challenge when we use big data, is that we have this transactional data, and we want to look at the sequence of events across time, and we want to be able to do some pattern analysis using that sequence of events. And I think this slide shows you generically that this is something that's very important for healthcare. Also, when you look at banking transactions or purchases. But I think for healthcare, it's particularly important because the temporal context, the ordering of the care the patient receives, how long the time difference was between care, are really important factors when we think about quality of care and outcome of care. We can't separate those factors out from the sequence of things that happen to a patient. So here in this timeline, you see that there's some event A, some followed by some event B, and then there's somewhat a repeated pattern of a CD and E, for example, that occurs with this patient. And so those are things that we like to be able to discover using some big data analytic techniques, in this case, the sequence alignment, which scales very well to this problem. So just to summarize, we know that this longitudinal data, it's a type of big data. A lot of the issues that we have with big data analysis is that they don't really consider the temporal component within the data, and in particular, we're interested in the distance between the transactions. So how long does it take, for example, for a patient who's been diagnosed to get the first treatment, or are there delays in the treatment? And so we want to incorporate that. So we work to extend our approaches here that I'll mention briefly in the bioinformatics approach, to look at the similarity between templates. And in this case, templates are either guidelines, or they could be clinical trial information that might be presented in the longitudinal data. So we're looking to match patients not to each other specifically, but patients to known treatment guidelines. So this just shows you, let me just go through this animations here. So we have a series of data from our electronic health records, which we convert into these sequences. We look at the events, and we look at the timing between the events. And then we encode the information that's from those sequences into a pattern, which is shown here. So the way this pattern is modeled for you is that the first, what's in red is appended to the event. That's the amount of time between the event. For the first event, there's no previous event, so it gets a 0. And then the second event here, B, gets the amount of time that occurs between A and B incorporated and so forth. So we incorporate the timing into the sequence representation so that we can use that information to be able to determine delays and other factors that are occurring. And this is particularly important when we try to match to treatment plans, and particularly in breast cancer care. There are a number of treatment plans that look exactly the same, but they differ because the amount of time that's supposed to occur. So if we just use plain sequence alignment, we wouldn't capture these distinctions between the time between treatments. And so here's an example of that where we have a regimen that has 2 drugs that are supposed to be given together every 14 days for 4 times, followed by another drug that's supposed to be given either once a week, as shown in the first regimen, or as 14 days shown in the second regimen. And then the regimens can be very complex, as shown in the third regimen. There's all series of drugs that we can give in certain orders. And so like the patient sequences, we take these regimens, known regimen, treatment regimens, we encode them into our model so that they represent in the same format the patient data is being represented. And so our goal here with this approach is to be able to use sequence alignment, which I mentioned is quite widely used in bioinformatics. It was very critical to the Human Genome Project to have these sequence alignment approaches because, as many of you know, when you take the human genome and you digest it, you get fragments of sequences, and you have to reassemble the sequences with each other. So you have to do some overlap matching. And then when you look at genes and specifically region of interest, you have to have something like sequence alignment to basically look at the data. And so we're envisioning that when we get all this data from electronic health record systems, we'll need something very similar to be able to align patients where there might be fragments of data across from different health systems, and there might be common patterns that we need to look across patients. So there's a well-known algorithm here called Newman-Lynch. It's been developed 30, 40 years ago, and it's important for us to know that this algorithm will do the best job it can, which is what we're working on. It doesn't account for the temporal distance between the sequence elements, so this is what work that's presented this year to try to figure out how to incorporate time into the sequence alignment algorithm. So, and this is just to show you what some of the issues are between that when we try to do these alignments. So the first sequence here has 4 events, A, B, and C, and D. These could be, different treatments like surgery, chemotherapy, hormone therapy, radiation therapy as the events. And there's some amount of time that occurs between them. And then we have a second sequence that is say, it's surgery followed by, for D might be chemotherapy. And so normally with sequence alignment, you'd compare the first A and the B with the first A and the D. But you can see there's actually a really good alignment match where these 2 patients, if they were sequences representing patients, are actually similar in the fact that they both got A and D, and it was about the same time apart. So we want to be able to incorporate that timing information to say that B and C matters, but it doesn't matter the fact that A and D align as well. So there's a way to basically score the alignments, which is important to be able to then say how close these alignments are to each other. And then we can use this algorithm, which I won't go into too much detail, basically to look at how close the alignments are between those 2 sequences, A, B, C, and D, and A and D, and we can get a score of what the optimal alignment is, which is shown on the right there, where the best alignment is actually sticking in 2 insertions between the 2 sequences. Again, this is important if there's missing data in our case, or if the patient has received care somewhere else and we're just missing the timing of information. This alignment will allow us to incorporate and say that, from the data we can see that there is a good alignment based on timing. So I will skip this. This just goes into a little bit how we change the scoring scheme to work on this. And I'll just talk a little bit about the quality of this. So we had, interesting enough, we had about, of the 900 patients that we extracted breast cancer care from 2011 to 2014, we looked at the patients there, and we found that about 20% of the patients had received chemotherapy. Again, that's lower than we expect based on the previous data. And it turns out when we went to look at that, some of the systems that would have gone online to capture data hadn't captured data, and there was data being captured that was on paper still, which was unknown to us. So we did miss some cases of patients who had gotten chemotherapy, but we're not in the system. In this case, we're not looking at the rates, we're just looking at the ones we did capture. And then we went and looked at the data and said, how much of this data actually, we manually annotated the data to the appropriate chemotherapy, and then used our two algorithms to find the best approaches. So the Needleman winch is the standard out of the box, and the Temple Needleman winch is the one that we just showed you to incorporate time into this. And you'll see that what happens in the first part is that there are patients that we could not resolve which regimen they're on because we couldn't incorporate the timing. So some regimens looked exactly alike, as I mentioned, so there was a tie basically between those two regimens where the patient matched them. When we used the temporal version of our algorithm, it did a very high accuracy of matching patients to the right protocols. And so we're using this as a way to encode that data from encode the protocols from the data so that we can have that part of our analysis going forward. So the other thing that we've done, because of the nature of the data we've actually started looking at the networks of care provided in the data. And what we can do using this network science approach is that we can represent patients and physicians as nodes in a network and see how they're connected through each other in terms of their patterns of care. In this case, we decided to create a patient sharing network where a physician network, which is patient sharing, where every node in the network represents a physician who's given care, and the links between the physicians are based on a patient they've shared together. So in this slide, what we've done is, that's just what I said, I'm sorry, this is summarized about how do we look at this. We create the social network. And in this slide, you'll see that we have the network displayed here. So just to walk you through this network here, we have the part that receives care, the other part because that was encoded in the registry data. We have this interesting group of people at Stanford that are surgeons, that are private practice surgeons who operate in our OR. So their data is being collected by our system because they're providing care, but they're not part of Stanford in terms of its network of healthcare. And then in the top set, you'll see all the surgeons, which are in red color. In the middle set, you'll see the medical oncologists, the ones who give chemotherapy, and then the hormone therapy. And in the bottom, you'll see the radiation therapists there. And we put them in the order of the care they normally receive, although sometimes the care, someone can go get surgery, they may stay with the medical oncologist, but this is the typical pattern of the care and this ordering. And then, as I said, we have the two sites, and then the size of the node you see here is equivalent to the number of patients that physician saw, and the line, the thickness of the line indicates how many patients they shared. So if you just look at the PAM side, you'll see there's one medical oncologist there who is really a key person in their network here, where many of the surgeons are referring to that medical oncologist, who then is also connected to a lot of the radiation oncologists as well. And you don't see here on the Stanford side anything that's that tight in terms of one node being critical. And you'll of course see the patients that are moving between the sites in terms of the links that go between Stanford and PAM. And so we're using this network analysis to now then overlay it with the use of the care and see how well the treatment pathways, the network itself influences this care. And so this is analysis that we're doing now with both the Stanford PAM data set as well as data that we collected at Dartmouth-Hitchcock with the data I showed you previously to look at these patterns. So it's very exciting in terms of using some of the big data techniques that exist out there, applying it to the healthcare data sets we have from our systems, and being able to look at population level patterns of care. So and this one is just interesting because it just shows you the tightness of the network. So if we create nodes which represent the entire surgical practice, medical oncology practice, radiation therapy, you can see the connectivity. It's much more flow going on the PAM side than is on the Stanford side, which is not too surprising. PAM being a community-based care organization, patients clearly, it shows here, tend to stay in the system, where Stanford being a tertiary care, since patients are coming in and out from other sites. But this just confirms what we would expect to see in this kind of healthcare environment and competition. So, So all the work that I presented today is what, to me, are the foundational building blocks of what we're calling the learning health system, which is, as many of you know, a new kind of effort across many different institutions at the NIH and elsewhere, where we're thinking about how we are able to get data in, look at what the challenges are, in our case, quality of care, the timeliness of care, design interventions within the healthcare systems, implement those interventions, then look at the data again to see if we've improved quality of care. And this is supposed to be a very rapid learning cycle of doing this. We, of course, need to have IT in place here at all stages to make sure that the information that we're collecting is of high quality, that it's actionable, and that the information we're putting out in the back end of the system is helping to improve the system going forward. And this is really, for me, the big challenge in the field right now is how we can take all the clinical research we're doing and help move the whole healthcare system forward with using informatics as the sort of the platform by which we do it. So this is the last slide here. I just wanted to end on this, that some, the obvious lessons I think are from this informatics odyssey, as I call it, because it's certainly as we went off on this journey of being one of the, this is one of the largest data sets on breast cancer and cancer care, and doing this work between different institutions at the level of details we were collecting from this data, we realized all the challenges that come from that. So it's very important to understand the source of data and not just to use the health record data as the ultimate truth, because we think there's many limitations in that, as I pointed out. And we need to be able to get more data and to help us to fill in the gaps, ensure that the information we collect is of high quality, and so we can use that. And there's an opportunity for us in the field of data science and informatics to be able to develop new methods. In my particular area, I'm interested in longitudinal data and looking at pathways, but there are many, many aspects of this data that need new methods, and that we're very excited to be sort of working on that to help build a learning health system with the methods. So I will end there, and I will have time to, I believe, take some questions, and I'll turn it over back to the moderator.
Yes, at this time we are moving to the question and answer session. To ask a question, please *6 to unmute your line.
Hello, am I muted? Can you hear me?
Yes, I can hear you, yes.
I just wanted to start with one question. So thank you for your presentation. In the substance use area field, I don't know how much you have experience with us. One of the things you suggested for breast cancer is to start from registries and then from there then use electronic medical records. And then you describe how you went through the two systems and anonymized data and so on. But in the substance use area, as far as I know, there are very little to no registries. Have you had an opportunity to discuss how we can start this a similar work in this field?
Yeah, so that's a great question, and I know that with cancer, these are reportable conditions, so there's a system in place, effectively, with people who go through the data and collect the data. My thoughts with substance use disorders and mental health disorders in general is that we know there are a number of people who do screening and will use various research-based diagnostic processes, basically, to determine what the diagnosis is with patients with substance use disorders. And so those patients, if they're willing, we can, consenting, we can use those patients to determine what is the ground truth in terms of patients we know that have the condition. If we link it back to other sources of data, we can figure out the criteria based in those data. So a classification process to help us determine what information do we have collected already in electronic health record data that can help us determine with high probability that the patient has a particular diagnostic code. So historically what people have done in this field without using some of that data mining approaches, they've taken a certain number of criteria. For example, it's hard to determine who has type 2 diabetes in electronic health records. So some people will take a look at whether the patient has a hemoglobin A1C, a measurement of their glucose level. Another group will look at how many times they've been diagnosed with diabetes and use a number of criteria. And so those have all been very rudimentary approaches, but if we have all this data, we can actually start thinking about, through the data, what's the source of information here that helps us determine whether the person has substance use. But we'll still need to have some ground truth, so to speak, to be able to connect those two pieces together. Otherwise, we'll always be doing with some probable matches if we use other criteria, just electronic health record data alone.
Okay, thank you. Just remember, what is this, a *6 or #6?
*6.
*6, okay.
Well, I'm curious if anyone who was on the call actually found what I've said was surprising. It always surprises me when I work with the data, but and having done clinical research and having used electronic health record systems as a clinician, I'm surprised that what we got at the other end is not quite where we need it to be. So this is hopefully just getting through that space of thinking about how we can control for those issues, as well as think about new ways to use the data that we hadn't thought about before.
Is my phone unmuted? This is Udi. I have a question.
I can hear you, yes.
Okay, I wasn't sure. So thank you. It was wonderful talks. Implementing a big healthcare data science approach and inclusion of EHR-related data relevant to a learning healthcare system for substance use, to me, seems to require substantial infrastructure development for both data collection and informed consent management.
Mm-hmm.
Since there are issues related to inclusion of substance use treatment information subject to federal confidentiality regulations,
yes.
et cetera. So how do you foresee such needed infrastructure being built and supported toward a learning healthcare system for patients with substance use problems given these issues?
Yes, that's a great question, and I've been working with some of our faculty here who do substance use care and research, and so this is just an example of a project that we were looking at. One is, so you may be familiar, probably everyone's familiar here with SBIRT, these short interventions that one can do within the primary care setting, for example. We can train primary care doctors who recognize someone who has substance use disorder to do an SBIRT, and so there's a number of things there. If we want to do this as a study, one is that we'd have to consent, and so that's very true that consenting is an issue, just not in substance use, but across all research areas. We've been looking at how to extend the patient portals and that come with many of electronic health record systems to do the consenting of the process. We also looked at those patient portals as a way maybe electronically delivering SBIRT as well, and that it could identify the individuals and show them materials to have for the short intervention. So technology there can play an important role. But if we were to then look at actual SBIRT use in practice, we'd have to look at documentation, or if it's billed for, something like that. And that would help us to capture in practice what's happening. But this is the challenge we have, which is that we need to improve the quality of the documentation and structuring the information on the front end so that we can do high quality research with that information. That's not as much IT issues, but it's more about the what we call socio-technical aspect, how people use the technology, how can we effectively engage them to make sure that information they're putting in is useful for other purposes. And as many of you know, physicians are very busy and they're struggling with these technologies often in real practice, and so we want to be sensitive to those factors as we try to improve the quality of information going in.
Yeah, so my question was in regard to consent management for vulnerable populations, which have additional layers of protections and confidentiality safeguarding. So
you mean the protection of the privacy of that?
Yeah, for example. So
right.
What is your experience dealing with mental health populations that have those constraints, and how
Right.
a big data science approach to that patient population.
Right. So in terms of privacy there, one of the things that obviously we'd like to do is ensure that only the individuals who need access to that information will get that information. And some of that information and some of the issues in terms of gathering that information in clinical settings, the regulations that are there are by the state and the institution themselves and protect information. With consenting, it's a little different, right? So we're not looking just at the privacy information, sensitive information. We're looking at people who've decided to become research participants, and so there's another layer to protect them as research participants. And so I will tell you, there's no single answer. Our institution has struggled with this. We have, for safety reasons, and it's actually involved the Department of Psychiatry quite a bit, we've decided that to make knowledge, if a patient has enrolled into a study protocol which has a treatment intervention involved, then they show up in the emergency room, we want to convey to the healthcare provider in that setting that the patient may be on a medication or treatment that's not documented in electronic health record. And so there's a way to contact the PI of that so that we can at least, where it's appropriate, release some information for the healthcare provider who's not involved in research. I don't know if that directly answers your question, but in terms of understanding how to look at those factors, we have to be very sensitive about the rights of the person as a research participant, as well as in terms of providing enough information to a healthcare provider that they can provide accurate, appropriate care at the time of emergency.
Okay, thank you.
Any additional questions?
Hearing nobody come for more questions, I would like to thank Dr. Das for a great presentation on what are the issues we're going to be facing in moving in this direction. And hopefully we will be working together in the future through the Northeast Node and Lisa Marsh group in order to help us in starting gathering data from electronic and medical records and other sources. I would like to thank all the people that attended the call. I just want to remind that our next call will be January the 26th, and we will have information pretty soon on the speaker on that one. But it's going to be basically about privacy and security in general, which it was a topic that was here today as well. So thank you, everybody. Have a great afternoon for everyone, and have a great holiday season. Bye-bye.
Thank you very much. Bye.